So nitroglycerin, it can be used both in the treatment and prevention of angina pectoris, but usually in the treatment of angina. Okay, so that's where we're going to really focus on this, usually in the treatment of angina. Okay, there's a rapid acting form. Okay, so you guys have probably, those of you who work in clinics or in ER, have seen the rapid acting forms. They go sublingually under the tongue or can be used as a spray. So there are rapid sublingual forms. I should just say form. There is a spray. There are transmucosal tablets, all sorts of things. There are some longer acting regular tablets. We don't typically use those as much. There are some sustained release ones. Just know that sustained release, we need to know we can't like split in half, we can't crush them, those kinds of things. So we want to prevent attacks from occurring. IV nitroglycerin is for severe unstable angina attacks to control blood pressure perioperatively and to treat heart failure after an acute MI or myocardial infarction. Okay, so unstable angina and MI are some of the most common. Okay, so that's therapeutically. Okay, does come in a rapid sublingual form, right? Therapeutic in the treatment of angina. Okay, so let me explain to you how it works with this pharmacologic action or biochemical action. It works through a series of enzymes. Okay, so there's a series of enzymes that are affected. It absorbs into the bloodstream, and nitrate changes acid into nitric oxide with the help of an enzyme called sulfhydryl. Okay, now you guys are going to listen to me saying this, and you're going to say that is just TMI, right? So I'm going to tell you what's important as we go through this. Following a series of those reactions, there's a dilation of vascular smooth muscle, okay, of the primary coronary veins, and in a lesser way, the arteries, okay? So vascular smooth muscle dilation means vasodilation of the vasculature, so the vessels, that feed the heart, so of the coronary vasculature. Okay, that's basically it. Venous dilation also occurs, which is kind of odd, but that's because of that nitric oxide pathway. Okay. It also decreases preload. Cardiac preload. And this is one where I always have to tell students, yes, you got this in your pathophysiology, but we're reviewing it right now because a lot of people really don't remember this stuff or really haven't applied it to something. So by decreasing cardiac preload, we're putting less stress on the heart. Cardiac preload is kind of referring to what fills the heart prior to squishing all that fluid out with that heartbeat, okay? And so it's kind of like if you were to shoot a gun, what you would load the gun with. You would preload it before you shot it. And that's exactly what it's talking about. We would preload this with fluid before we squished it. Well, this medication allows for decreased cardiac preload, okay? Because, and it's partly because of this vasodilation that occurs, okay? And it does require then less force to expel blood from the ventricles and reduce the oxygen needs of the cardiac tissue. So, decreases the work of the heart to pump, okay? And in turn, then reduces oxygen need. The harder your vessels, or the harder your heart is working during an MI, can determine your outcome, okay? Big time, okay? So let's talk about this medication a little bit, okay? And let's talk about the adverse drug reactions, okay? Adverse drug reaction happens in almost everybody, a headache. Because of that pathway that is incited, it also works on some vessels in your head. A person is going to get a headache. Now, it does not mean we're going to stop or hold the medication. This is one of those side effects where we're going to say, well, you know what? The headache is better than dying of a heart attack. So we're going to give the medication, okay? Orthostatic hypotension, okay? So orthostatic hypotension can be a problem. So that is orthostatic hypotension, again, is when people are lying to sitting to standing. So this would be of particular interest in the person who's getting one that's a little bit longer term, a little bit longer acting. We'd have them rise slowly, right? You should know that, right? You should be able to make that assumption for anything that causes orthostatic hypotension at this point, because you've seen that a lot. Now, hypotension in general, severe hypotension, is a side effect, okay? I don't think it's listed in ATI, but just know severe hypotension itself is problematic, okay? So if that person's blood pressure is low, we don't want to be giving this, right? We're going to question it. Now, here's the deal. When we give it in the ER, and we go ahead and we've got this patient who's there who's 150/80, and they have 10 out of 10 chest pain, and we give this medication, it might bring their chest pain down, but all of a sudden, on a rare occasion, it will dump their blood pressure. And you need to know that, especially those who are having a right-sided MI that we might not know about, those people in particular can really dump that blood pressure, and it can be very dangerous. So we always have fluid hanging and ready to go, and we've already got that IV going. It's not that we've already started it. We're going to wait for the provider, or not wait. We're going to be proactive in asking if we should start that and how fast we should run it, that kind of thing. But if that severe hypotension occurs, that fluid is right there ready to go. So if your provider said open it wide open to get that blood pressure up, you've got that that fluid up and ready to go. Okay, so tolerance can occur. So there's that. I'm not as concerned about the tolerance as I am the severe hypotension. Some reflex tachycardia can happen. You know, it brings down the blood pressure, And so some of the things that are making sure that we maintain homeostasis in our body will say, oh my goodness, it just brought down cardiac output. And remember, I hope you had this in pathophys. Cardiac output equals heart rate times blood pressure. And if your blood pressure all of a sudden drops, your homeostatic mechanisms in your body are going to kick in, and they're going to cause a little tachycardia, right? So that you can keep up that cardiac output, okay? So maybe we'll just leave that right here. So you just keep that in your mind, right? And I might just copy that for later. So that's a little bit about nitroglycerin. When we give it sublingually, let me just... When we give it sublingually, because this is the most common way to give it, sublingually, we'll give that dose every 5 minutes. And we'll get vitals prior to giving it again. We usually give it up to 3 times sublingually. And then oftentimes in the ER we'll start a drip if they need it to continue. Okay? So that's just kind of insight into how we use it in real life, right? So I'm going to stop that and we're going to move on to the next drug.